After studying this module, you shall be able to know about the significance of decontamination of poisons, the elimination procedures applied in the case of absorbed and unabsorbed poisons, and the various types of antidotes and their importance. So students, let us begin with the introduction of this module. For a forensic toxicologist, while the objective is the interpretation of the characteristics and nature of a poison in case of poisoning, the foremost purpose before a medical practitioner is to save the life of the victim or the individual before the said poison starts functioning and assumingly onset of functioning. During the course of his duty, a medical practitioner has to face such tasks frequently when he has to make decisions in either ways to assure the benefit of his patient. Very often poisoning cases are reported before a doctor which may be accidental in nature also. It appears not important to discuss about the suicidal or homicidal poisoning because generally in those cases the victim is dead and nothing much is left for a doctor to exercise except the post-mortem examination. The doctor will be confronted with choices on management and disposition for which the considerations are decisive to determine if the patient can be successfully or safely sent home with advice, supervised in a short stay unit before being discharged, or admitted for monitoring of target organ impairment and specific supportive care. For a doctor, decreasing further exposure of the patient to a toxicant is important and may contain removal of the patient from a toxic surrounding and the use of decontamination procedures. Decontamination is intended to prevent or curtail further toxicant absorption and to promote excretion or elimination of the toxicant. Decontamination should be considered a most important treatment. Awareness of the fundamental mechanism of action, pharmacokinetics like absorption, distribution, metabolism, excretion and toxic dose of the toxicant is vital in determining correct decontamination therapy for the patient. Immediate decontamination moderates absorption of toxic compounds and signifies a primary essential feature for the treatment procedure also. Next students, we will study about the forensic issues. The causes for toxic exposure are as extensive and diverse from recreational use to abuse of medication to accidental home or the occupational exposure, deliberate self-harm and environmental pollution. The clinical range of poisoning therefore consists of acute, subacute and chronic intoxication also. The mortality from toxic exposure is low with good supportive care. Hence, the foremost task for a medical practitioner is to recognize promptly those patients who might develop severe complications and those who might potentially benefit from specific interventions. It is distinguished that all chemicals are potentially toxic to humans at specific dosage. However, the factors for determining individual toxicity are multifactorial. In order to predict health effects from the chemical exposures, certain accounts are to be taken such as the characteristic toxicity of agent, the physicochemical properties of the toxin, the exposure dose, the route of exposure, the physiological and genetic factors of the individual, also in some cases the environmental factors, especially for exposure through the inhalational route. Next, we will study about the elimination of unabsorbed poison. Elimination of the unabsorbed poisons depends on the mode of intake of the poison, and under this category we first have the inhaled poisons. In the circumstances of poisoning by inhalation, the victim should immediately be shifted to fresh air, a clear airway should be ensured and simulated respiration initiated simultaneously. In some cases, the respiratory center of brain may be stimulated by a mixture of 95% of oxygen and 5% of carbon dioxide. Next in line is the injected poisons. The use of tourniquet above the spot of injection may slow the absorption rate. The tourniquet should be loosened every 10 minutes for 2 minutes, imbibe the poison by creating incisions at the spot, and use chemical antidotes, cold packing and vasoconstrictors, example injection of epinephrine to prevent absorption. The common examples of injected poisons are hypnotics, insulin, snake or other insect bites, etc. In case of contact poisons, in contact poisons affecting the skin, mucous membrane, any wound or introduced in the uterus or vagina, they should be washed with water and neutralized by application of suitable chemical. If the poison is applied to the eyes, skin or wound, the poison is removed with specific antidotes. Next is ingested poisons. The poisons are most commonly ingested orally. Depending on the time lapsed after ingestion, much of the poison lying unabsorbed in the stomach should also be removed. Under this, first we have the stomach wash or the gastric lavage. Gastric aspiration and lavage is the only suitable method of emptying the stomach of an unconscious patient. In unconsciousness, protect airway with curved endotracheal tube. Before carrying out a stomach wash, the patient should be lying in a left lateral position or in a horizontal position with the head hanging over the edge of the bed and the face is positioned downwards so that the mouth is at a lower level than the larynx and chances of aspiration of fluid are eliminated. The gastric lavage tube is gently passed into the stomach through the mouth by lubricating it with glycerine or Vaseline jelly up to a distance of 50 centimeters in adult and 25 centimeters in children. The position of the tube in the stomach can be checked by a stethoscope or putting the upper end in a cup of water. If the lower end is entering the trachea, air bubbles will come out. For carrying out a stomach wash, initially 250 to 300 milliliters of warm, that is around 35 degrees centigrade saline or plain water is passed through the funnel held high up. In children, instead of water, 10 to 15 milliliters per kg body weight of the warm saline is used, as in them there are chances of inducing hyponatremia and water intoxication. The stomach contents can be siphoned by the use of suction bulb. The first sample of stomach wash should be preserved for chemical analysis. Next is emesis. Emesis are the substances which produce a gagging effect. Most poisons are themselves emetics and may cause vomiting. However, it is worthwhile to give an emetic to ensure a more exhaustive emptying of the stomach. Emesis is easier than the gastric lavage and less distressing for the patient, and if the patient is conscious and cooperative and vomiting is not contraindicated. The emesis should be avoided as there is a risk of aspiration of stomach contents in an unconscious patient. Emesis should be avoided in corrosive poisoning for the fear of damage of the esophagus and stomach also. It must not also be used when there is danger of aspiration into lungs, either from the volatile poisons like petroleum distillates or from the inhalation of the gastric contents due to the impaired consciousness. Emesis should be induced either by tickling the fauces or by emetics. Vomiting can be produced by the use of emetics, of which ipecac is the most effective, whereas mustard powder and warm saline can give rise to complications. Next technique is catharsis. Catharsis is a very appropriate term used in connection with poisoning, since it means purification. It is done by purging the gastrointestinal tract, particularly the bowel, for all the poisonous substances. Cathartics lessen the travel time of the poisonous substances in the GI tract, but their efficacy in reducing the mortality or morbidity is not established as such. There are two types of catharsis. First is the saline cathartics and second is the saccharide cathartics. Next is elimination of absorbed poison. After a substantial absorption of poison into the bloodstream has occurred, procedures must then be implemented to accelerate the excretion of the toxic agent, mainly through urine. Elimination by catharsis, when not contraindicated, and by sweating by means of hot packs may be encouraged also. Fluid administration to maintain sufficient renal function with phases of dialysis will be advantageous. In cases of aspirin and barbiturate poisoning, forced diuresis using intravenous chlorothiazide and or mannitol infusion have been substantiated valuable. However, the forced diuresis is an obsolete process and not recommended by the medical practitioners. Peritoneal dialysis has also been recommended for salicylate poisoning in children. Hemodialysis has been used for eliminating barbiturates, bromides, glutathione, methanol, salicylates and thiocyanates for the blood. Exchange transfusion is only feasible with small children and has been applied to poisoning by salicylates, barbiturates, iron salts, carbon monoxide, etc. All toxic substances are removed by this technique. There are various methods for eliminating the absorbed poisons from the body, and here I will be discussing some of them. First is the hemodialysis. The three elementary components of hemodialysis are the blood delivery system, the dialysate itself, and the composition and method of delivery of the dialysate. For acute hemodialysis, catheters are generally placed in the femoral vein and passed into the inferior vena cava. Blood from one is pumped to the dialyzer through lines that contain equipment to measure the flow and pressure within the system. Blood returns through the second catheter. Dialysis begins at a blood flow rate of 50 to 100 milliliters per minute and is gradually increased to 250 to 300 milliliters per minute so as to give a best clearance. Next is hemoperfusion. This is a technique that is progressively becoming popular since it is capable of removing many of the toxins that are not removed well by hemodialysis. An arteriovenous shunt or a double lumen venous catheter is inserted into the patient's vascular tree. The hemoperfusion column and lines are primed with heparizer saline and connected to the shunt or a catheter. On commencement of perfusion, a bolus of heparin is injected into the arterial line and heparinization is continued by administering an infusion of the heparinized saline. Next is the peritoneal dialysis. Peritoneal dialysis works on the same principle as hemodialysis, allowing the diffusion of toxins from mesenteric capillaries across the peritoneal membrane into the dialysate dwelling in the peritoneal cavity. It involves the insertion of a stylet catheter at the bedside under the local anesthesia or the surgical insertion of a catheter in the abdomen. Dialysate fluid is instilled and around 1 to 2 liters is exchanged each hour. Next is the hemofiltration. Hemofiltration is performed similar to hemodialysis except that the blood is pumped through a hemofilter. An arteriovenous pressure difference induces a convective transport of the solute through a hollow fiber flat sheet membrane. This allows a substantial flow of plasma water and a high permeability to compounds with molecular weight less than that of 40,000. The procedure can be done intermittently at high ultrafiltrate rates of up to 6 liters per hour or continuously at a rate of 100 milliliter per hour. Next is plasmapheresis. Plasmapheresis is a technique of separating the cellular blood components from the plasma. The cells are resuspended in either colloids or albumin or fresh frozen plasma and then reinfused. It is very effective in eliminating the toxic substances but exacts a heavy toll. Next, we will study about the application of antidotes. Antidotes are remedies to counteract the effect of a poison. They are used because the poison may not have been completely removed by emesis or lavage, or the poison is already absorbed, or it has been administered by other route than the ingestion. According to their mode of action, the antidotes are divided into several classes. First is the mechanical or the physical antidote. The mechanical antidotes counteract the effect of poison mechanically, preventing their absorption without inactivating the damaging action of the poisons. They are of various types. First is the activated charcoal. Activated charcoal is a fine black, odorless and tasteless type of amorphous carbon prepared by destructive distillation of materials such as burning wood, coconut shell, bone, sucrose or rice starch that have much higher surface area than the charcoal, followed by treatment with an activating agent such as steam, carbon dioxide, etc. The large surface area of activated charcoal confers a greater absorptive capacity to this material. Next in line is the demulcents and bulky foods. Demulcents produce protective coating over the mucous membrane of stomach to protect it from the action of poison. They are milk, egg white, starch, milk of magnesia and aluminum hydroxide gel. Bulky foods like bananas, boiled rice or potatoes allow a smaller amount of poison to be available to the stomach mucosa for absorption as they are admixed with the poison itself. The bulky foods are commonly used in ingestion of glass powder as these particles are embedded in them and they prevent the damage of the stomach mucosa or the stomach lining. Diluents such as water, milk or other similar drinks dilute the poison and delay their absorption rate. Next are the chemical antidotes. The chemical antidotes disintegrate and inactivate the poisons by undergoing chemical reactions along with the poisons and forming harmless or insoluble compounds. In corrosive acid poisonings, weak non-carbonate alkalis act as neutralizers. Strong alkalis are avoided as they can cause further damage to the stomach. Non-carbonate alkalis are preferred as the carbonate alkalis react with the acid to produce carbon dioxide gas that inflates the stomach and may get ruptured also. In corrosive alkali poisoning, weak vegetable acids like citric acid and acetic acid such as vinegar, lemon juice may also be used. For arsenic poisoning, freshly prepared solution of ferric oxide can be used as it forms non-absorbable ferric arsenate. Albumin is used for mercury poisoning as it precipitates mercury chloride. Copper sulfate is antidote for phosphorus. Potassium permanganate is an oxidizing agent used in poisoning with oxidizable substances like cyanides, phosphorus, atropine and other alkaloids. A dilute solution of the potassium permanganate is used in any poisoning such as aluminium phosphide, opium derivative, insecticides, nicotine, cyanides, hydrocyanic acid, atropine and strychnine, etc. Tincture iodine or Lugol's iodine in a solution of 15 drop in half a glass of water precipitates lead, mercury, silver, alkaloids and strychnine. Tannic acid, that is 4%, or a strong tea or 1 teaspoon full of tannic acid dissolved in water is used to precipitate metals like lead, mercury, nickel, zinc, copper, aluminum, cobalt and silver. Then next comes the physiological antidotes. The physiological antidote acts on the tissue and various systems of the body and they produce signs and symptoms opposite to the signs and symptoms produced by the poison. They are basically of the use when some of the poison has already been absorbed into the circulation. They antagonize the effect produced by the poisonous substance. These are like the atropine or for organophosphorus compounds, physicostigmine and neostigmine for dhatura and barbiturate for strychnine also. Next, we will study about the universal antidotes that can be used for each type of poison. It is used for the characteristic of a poison that is not apparent or when a combination of poison is suspected. It consists of a mixture of various substances such as the powdered animal charcoal 2 parts with adsorbs alkaloids. For magnesium oxide 1 part that will neutralize the acid, tannic acid or strong tea 1 part for alkaloids, glucosides and metals. Next are the chelating agents. Certain chelating agents are widely used as specific antidotes against some of the heavy metals. These substances produce a firm, non-ionized cyclic complex that is chelated with the cations. Such compounds can form stable, soluble, non-toxic complexes with calcium and certain heavy metals. They are BAL, that is dimercaprol, EDTA, ethylene diamine, tetraacetic acid and penicillamine and desferoxamine, which are used in heavy metal poisoning. Now students, let us summarize this module. The diagnosis and treatment of human poisoning come under the study of clinical toxicology. It includes the superficial or probable identification of suspected toxicant and its decontamination. Decontamination involves removal of toxins from portals of entry before absorption into the bloodstream. The entry of toxins into the body occurs via the oral, inhalational and dermal routes. The method used for decontamination depends on route of poisoning. The clinical evaluation of the poisoned patient has the primary objective of cataloging poisoned patients into mild, moderate and severe categories of poisoning by obtaining a targeted history, performing a careful physical examination and a specific laboratory evaluation. Therapeutic interventions for poisoning include decontamination, techniques to enhance elimination of absorbed toxin and use of specific antidotes. Enhanced elimination of absorbed toxin involves the use of interventions that attempt removal of toxins that have been absorbed and circulating in the bloodstream or distributed to the tissues. The first clinically useful chelating drug was the British anti-leucite or the BAL, that is 2,3-dimercaptopropanol, which was developed during World War II as an antagonist to arsenical war gases.